The ACEs Optimist Show with your host, Dr. Craig Morris.
Hi, everybody. Welcome to ACEs Optimists, dedicated to optimizing human potential in the clinic of life. Today's guest is Dr. Donald Murphy, my longtime friend and colleague of, I think, about 30 years now. Nobody in healthcare that I've met in my over 40 years really epitomizes this concept of optimizing human potential more than Dr. Don Murphy. And what's probably also interesting is we could almost say that there's twins. There's an initial Don Murphy, an earlier part of his life, who then transformed into a very different Donald Murphy. So with that unique introduction, let me introduce to the show Dr. Don Murphy.
Hi, thanks for having me. I'm excited to be here.
I'm so happy to see you, Don. I thought we would start today because this show is especially dedicated to younger people, students who are going into healthcare. It could be chiropractic, physical therapy, medicine. The idea is during this day and age, it's, I think, increasingly daunting and difficult to understand, where to go and how to achieve excellence, how to make the most out of your capacities and being your best. And so as we got to know each other, I learned a little bit about your history as being something of a time in your life when you were finding yourself, and when you graduated from high school and you were kind of a beach bum, I think, and in the process of finding yourself. And so I thought we could start off just by getting a little bit of background, and then we could talk about the directions you've come, which have been monumental in, I think, in healthcare.
Yeah, it's been quite a ride. Most of our colleagues, the professionals that we've been friends with and interacted with, have gone, generally the standard route of, going to high school, excelling, graduating from high school, going to college, excelling there, graduating from there, going to professional school, and on and on. That's the standard way that things go. Well, that's not quite the way it went for me, simply because I was, when I was younger, it took me a while to find myself. And so when I first, when I was going through high school, I was kind of, the kid that the teacher would always say, "You have so much going for you, you're so smart, but you don't apply yourself." That was what I kept hearing from students. And of course they were right. I resisted that, but of course they were right. And so, I got through. And I ended up graduating, and after graduating from high school, actually my last year in high school, I started in theater. And so I decided that I wanted to become an actor. And so I went to school initially the first 2 years, and I studied theater. And so I went to a 2-year college in Long Island, which is where I grew up, and took theater. But as I was going along, I came to realize that theater wasn't really for me, or acting in general wasn't really for me. I loved doing it. I loved the craft and I loved the art. But I wanted to get into something a little bit more stable. Now, what that was, I had no idea. So what I ended up going through after that is a lot of instability, because I had no idea what I wanted to be when I grew up, and I hadn't grown up yet. So that's when I ended up moving to Southern California. I always wanted to live in Southern California. I always idolized Southern California, and so I moved there. And for about a year, I did basically nothing except hang out at the beach and have fun. But looking back, when I look at just that period of time, I think, well, I did nothing. I went nowhere fast. But looking retrospectively, I realized, no, a lot of things happened in my head at that time, because that's when I gradually matured and, kind of finally grew up. And even though I basically did no grown up activities at the time, the growing up was happening. And so, having gone basically nowhere fast, I ran out of money, and I said, well, I can't stay there. So I ended up moving back to Long Island. But in that interim, I had going through all that, kind of difficult times in a sense that even though I wasn't doing anything challenging, it was, there's no life to have. And so I ended up moving back and grew up during that time, matured a little bit, and I'm still working on that part, the maturity part. But I matured a bit at that point, and that's when I decided to become a chiropractor, and that's when I really got serious about life.
I think that's a great story. I remember us driving along the coast years ago, and I asked, I looked at it from the perspective of a parent at that point, and I still remember you introducing in our conversation the concept of incorrigible. You thought they'd kind of given up on you there for a little while.
Yes, exactly.
But in the end, it was a time of introspection.
Yes, exactly. And the I guess the life lesson there for young people today is that you may not know what where you're going. Even if you're embarking on a professional career, you may not know what you want to do with that, how you want to, make your mark, how you want to establish yourself, and that's okay, because fall in love with the process, get into the process, and out of the process will evolve the direction that you want to go, or the direction that's meant for you. So I think I'm a good lesson, as it turns out, for anybody who just doesn't quite have a good sense of where they are, where they should be going, what's best for them, what does the world expect from them, what does the world need from them. They may not have any idea, but that's okay. It's okay to be there.
There's an old saying that if you're going to take the fruit, squeeze every drop. You might as well. And I think that what you were doing is trying to figure out who you were, but I tell you, once you did, you really squeezed every drop out of your potential, or as much as any clinician, colleague, friend that I know. After you graduated from New York Chiropractic in 1988, and then I know you went on to get a diplomate in neurology, and you started in practice for several years, and we met in 1995 in September. We both had become interested in rehabilitation, started studying, and went to Prague to start to study with professors Karl Levitt and Vladimir Janda. And you and I met for the very first time just as I sat down at a bench at Professor Janda's. He had a rehabilitation clinic in south of Prague called Virage. Mm-hmm. And so we had a chance. We were there for a 2-week intensive course, rehabilitation course, understanding Czech manual medicine from the Prague School's world-famous, world-renowned approach. And that allowed us to have a chance to start to study together, become initially colleagues and acquaintances, and then friends. And then we both had enjoyed writing. So it turned out that we had this common background in writing. And then I was getting my diplomate in rehabilitation, and I learned, we were talking, you mentioned that you were in the process of writing a book, and I thought that's interesting because I had a teacher. I was a journalist in high school, and she wanted me to go into journalism as a profession. I said I'm interested in healthcare. She said, well, then write, because you're a good writer. So then you came out with your book, which was cervical spine syndromes, which I happen to have my copy of, a little bit dog-eared and notes all through it, because I don't believe great textbooks are meant to sit just on the shelf, but they need to be used and available, and to try to glean the gold out of that, out of the thoughts of the writers, the authors, and the time they put into it. And so, and I saw it and I liked it so much because it was multidisciplinary, and I was looking for a topic in a book and to write, and it was your book and your inspiration that said, I'd like to do a lumbar spine book, like a sister book. And I talked to you about that, and you connected me then with McGraw-Hill, and because you had, yours was from, yours was McGraw-Hill also, and you connected me with those people, and then I spoke with them, and then I ended up writing, a sister text book, multidisciplinary, and I think that together they have been quite good for the profession, and not just ours. I certainly didn't write it only for chiropractors, but for physicians and physical therapists, and certainly for students. And I think that, my idea was especially to use it because it was not multidisciplinary, to get us to be working more together. And I believe that was what you had in mind also, that seems that human nature is such that we tend to focus on differences among us instead of what we have in common. And you co-authored 4 chapters. We co-authored 4 chapters, I think, in that book. And then we had a chance to co-author a chapter in Dr. Scott Holloman's book also. And that is only the tip of the iceberg. So I'd like to talk a little bit more. You continue to write, you've continued to publish in peer-reviewed journals, and you've also continued to write additional books and go into little different directions as you've continued to grow. And I know that we discussed the fact that you already have published over 80 peer-reviewed journal papers, which I think the readers would have a hard time understanding exactly what this means, because there's a lot of people who are professional researchers, and if they can get up to close to 100, they've had quite a successful career. But you've done it as a full-time clinician, and this is unbelievable. And so I would like to let you share a little bit about what led you down this road, and then also towards your next career in primary spine care.
Yeah, it's a kind of a, looking back, it's kind of a fairly fascinating road. As it turned out, I didn't think of that during the time. I was just doing life, and right. But now it's I guess it's a kind of an interesting story. Well, the thing is that, and I think that when you were talking about each of our books, why did these books come out at all? And it's because they were inside of us, and then they had to get out. And we followed that inspiration, and we did it. And so, not that everybody in your audience is going to have a book in them. Not everybody has to have a book in them, but they have something in them. And finding that thing that is trying to get out and allow it to get out. That was I think a really the big lesson that I learned, and that's really, in the deepest level, I think that's why those books came out. They had a purpose from a professional standpoint, like you talked about, interdisciplinary, getting information out there and getting all the information related to, in my case, the cervical spine, in your case, the low back, getting all the important information together in one place where a student or a doctor or a therapist could have access to that. All those professional reasons, that was one of the things, that was the main thing that we were thinking about, was why we felt the need to put this book together. But really, when it came down to getting deeper, like I said, it was in us, and we had to let it out, and we did. And I'm so glad that we did, because I think that's a big life lesson for people as well. Because, like I said, you may not have a book in you, but you have something in you, something big. That may not be big, like, becoming a big bestseller necessarily in the broader scheme of things, but something really important for the world. And so, I think getting people to think about that is a big thing. And then, I was also, I first went into private practice after I graduated from NYCC in 1988. I went right into private practice because back then, as you well remember as well, there was not really options for a chiropractor other than private practice. You could associate with another chiropractor, or you could open your own. There was really not much else out there. Now it's a lot different, and at some point we can talk about that either in this session or another. But at that time there was not many options. So okay, private practice was it. And so I got into private practice and was, busy and successful and saw patients and had really enjoyed helping people overcome musculoskeletal problems, especially spine. But I knew there was something more that needed to be done. And I realized that, in trying to be the best clinician I could be, I thought about, well, how am I going to develop the knowledge and skills necessary to become the best clinician I could be? Well, one was the scientific literature, and so I followed the scientific literature very closely. But I also realized that the distinct limitations of the literature, that they told me a lot, but not everything I needed to know. And so I said, well, the only way that I'm going to impact that situation is by being a part of it and by contributing to the literature. And so that's what led me to start writing for publications, because it had to be done. Somebody has to do it. And not everybody is. There was a lot of great stuff, of course, out there that I was reading, but there were a lot of missing pieces there. So I want to contribute some of those pieces, a tiny bit of those pieces, but something. And that's what I started writing and writing for publication and doing research. And I had a busy practice, so I had lots of patients coming in with significant problems. And so there's my source of data, and I'm helping them, and I'm measuring the outcomes that I'm obtaining, and it seems like my outcomes are pretty good, but how do I know until I look at that systematically? And when I looked at that systematically, I've realized, yeah, my patients with cervical radiculopathy, lumbar stenosis are doing really well with what I'm doing. Well, why just keep it between them and me? Why don't I organize this way to do research, formal research on this, and publish the outcomes that I'm getting? And so that was the other thing that led me to want to publish my work. Fortunately, I connected with Dr. Eric Hurwitz, who you know as well, that he was an epidemiologist, still is, and he was able to partner with me in doing the part of clinical research that I didn't know, and that is the epidemiological part. So he's a brilliant epidemiologist. To think that some random guy in private practice could connect with one of the top epidemiologists in the world, that was pretty cool. I'm not sure how that happened, but I'm glad it did.
I think he contribute a chapter in your book also? I've forgotten.
Yep.
In your cervical spine book, because he did certainly co-authored the epidemiology chapter in my book. But again, Eric is a unique guy because he graduated from LACC, now Southern California University Health Sciences first, and then went back to school and earned his PhD in epidemiology at UCLA and worked there for a number of years until he got became really wise and escaped and went to Hawaii. And I think he's still there. Is that right?
As far as I know, yeah.
But he's wonderful. And another one. So there's so many things that you've stated here, and that I could take. And this is why I can. My goal here for you, you out there, is to call this session Dr. Donald Murphy Volume 1, because there's simply too much for us to talk about over the year and the directions we've gone and the idea we've grown together. I have said, I don't think we ever talked about this, but I have said, I don't know, dozens and dozens of times that I had this book in me that I had to get out of me. And so and you said exactly the same thing, because it's too hard and it's too much work unless you have the heart and the passion in order to do that. For me, it was almost 6 years. I think I always was amazed because you were much quicker writer than I am, and I don't know quite how long your cervical spine took for you to start and get it published. Was it 3 or 4 years?
I don't remember.
Yeah.
It was such a long time ago, but
Yeah.
it was a couple of years.
Yeah.
I don't remember exactly.
Yeah. So then we both studied with Professors Levitt and Yonda, and they had a huge impact on both of us. And I got into rehabilitation really because I wanted better results with less recurrences, and I wanted to push my patients towards more independence. Go live your life. Come back to me when you need it. Let's put a plan together so you can do that. And I needed more. I didn't really have very much training along those lines. We were trained more about the assessment, using manual techniques, and some ideas of how to try to give instructions of how to get longer term benefit. But I was always involved in sports, played a lot of sports. I was beach bum myself, so we have that common background. But the idea of then getting my patients to be more to understand more of the ideological aspects of what was bringing it on, and then what could we do to prolong the benefits and increase locomotor system function. And so that led me to the Prague School to study with them and to meet with you. And I know you also had some of those same points. But then as the years went by and after our collaboration, we kind of deviated a little bit. I went very much into like professional sports and athletics and medical legal issues and things like that. But and I think it's a perfect example of what's potential. What's our human potential, and where we can start with the same base, but find ourselves and go our own separate way. And this is, sorry guys, I'm getting a phone call coming in. I'm going to start back again. Was I interrupted, or was I still on?
It didn't seem like you were interrupted at all to me. Oh,
okay. So let me try to get back in to my thoughts. So we started to go in slightly different directions. My interest was sport, getting involved in working with elite athletes to get young youth, the youth, to optimize themselves athletically, to also work with medical legal issues and extremity work, quite a lot of extremity work. But you took a different route, and you were led towards primary spine care. So I'd like to ask you to just share with us, how you evolved into that, and then we could talk a little bit more about the phenomenal success and the impact you've had in your work.
Yeah, so it's interesting to look back also on that, how that evolution took place, and it really, for the most part, evolved out of what I learned in the Czech Republic, because the work of Yonda and Levitt, we learned a lot of different things, but most of it was about the spine, and especially in the example of Carl Levitt, I learned so many things that I never dreamed existed from him in terms of how to take care of a patient with a spine problem. And so what evolved out of that was, as you talked about earlier also, is going into rehabilitation, what we were calling rehabilitation at the time. And so I started teaching in the diplomate course for rehabilitation, I was doing that work, and we were talking about rehabilitation as if it were a specialty. But it came to realize is that all these things that we're doing, is this really a specialty or is this just good care for patients? And I came to realize that really what this is good care for patients. And so for me, it was really, how to take care of a spine patient with back or neck problems in the highest quality possible. That's really what it is. That shouldn't be a specialty. It should be just how to take care of patients. And so, but it also what came out of that experience with rehabilitation, what we were calling rehabilitation, is that there were different directions you could take that. I became fascinated with spine related disorders, back pain, neck pain, headaches, cervical related headaches, radiculopathy, differential diagnosis, as well as management and all that kind of thing. And that became my interest. And so I springboarded off of what we were doing in rehabilitation to just turn what we called rehabilitation into just appropriate spine care. And that's where I went in that direction. And so that was one thing that the evolution of that. But then as I was providing that good spine care to patients when they were coming in, and I started in my private practice, I was still in private practice at this time, and I was developing interdisciplinary relationships with primary care practitioners, but also with specialists. What evolved from that was that I was basically serving as a resource to traditional primary care practitioners because they had lots and lots of patients with spine problems coming in to them. They weren't super confident in their ability to manage them. They were sending them to specialists for whom their skill set was really was great and important for a single-digit percentage of those patients. And so, okay, so they came to realize that, but what do they do with the rest of the patients? The 90%, what do we do with that? As I developed those relationships with them, they came to realize that, oh, I'll just send them to Murphy. He knows what to do. He takes care of a lot of them. And if they end up needing those other specialty professional services, I'm confident in Murphy making that decision and figuring that out and coordinate that referral. And so that makes my professional life so much easier. Again, in the thinking of the primary care practitioner, that makes my professional life so much easier. I have my hands full with diabetes, hypertension, all those other things that I take care of. Boy, if I could just delegate this one area, one of the biggest areas of my practice, and the area that I'd rather not have to get really involved with, and find something, all the better. And that's where I evolved into that. Well, that started happening. And I was thrilled to get the referrals, of course, in private practice.
Right.
And I built a big practice with that. But what I came to realize is that, well, wait a second, I'm playing a role here in the community and it's a role that doesn't have a name. I was a chiropractor, but chiropractors, do lots of different things. So they get into sports medicine, they get into wellness, and they get into alternative primary care kind of stuff. And so chiropractors do lots of things. So to call this chiropractic, well, that doesn't fit. It's something very, very identified and very distinct. So what is this? And I started interacting with other colleagues, such as yourself and others, Brian Justice and John Ventura, that I work with now. I've been working with Dr. Michael Schneider and Dr. Pearl, Stephen Pearl, and we started having this conversation, and they were, realizing that, yeah, I think there is something going on here that is codifiable and identifiable. And so that's how and then interacting with Dr. Scott Haldeman, who had been talking about this idea of what we now call the primary spine practitioner. He was talking about this, well before we started having this conversation.
Wow.
And so, yeah, and we realized that, well, I think what we're doing is what Haldeman has been talking about should be done. maybe that's exactly what we are doing. And so as we evolved with that conversation, we ended up calling this the primary spine practitioner, which is that term applied so well because it's primary level care for patients with spine problems. So it's, not doing primary care because primary care is a generalist that takes care of everything, but it's primary level care working side by side with the traditional primary care practitioner, but taking care of patients with cervical and lumbar and related problems. And so that resulted in what we now call the primary spine practitioner.
And that led to the model, the CRISP
That led to the model.
To the
And
CRISP model.
So yeah, then a parallel story there is as I was applying both the things that I learned in chiropractic school and from Levitt and Yanda and from other sources that I sought training with, like the McKenzie Institute and neurodynamics and other areas, and then also following the literature carefully and seeing the evolution of what we knew about what's going on in the spine, how to understand what causes patients to suffer, both the somatic aspect, the neurophysiological aspect, the psycho-emotional aspect, how complex this whole thing is that causes a patient to suffer from back or neck problems. And I said, I have to somehow organize all this stuff in my mind: somatic factors, neurophysiological factors, psycho-emotional factors. They can happen in combination in any given patient, and I have to figure out which combination of things are most prominent in this particular patient. All right, well, if that has to be done, I have to do it. So I started doing that, working on organizing my thinking around that. Then a similar story evolved from, as we saw with the primary spine practitioner. Looking back on that, I realized, wait a second, this is an organized thing that I've done to, again, organize all this stuff, all this disparate information, all these disparate factors that cause people to suffer. And I figured out how to make sense of it in each individual patient, and importantly, in a really busy clinical environment. And so, yeah, there's something that is also identifiable and codifiable here. And so that's where, again, I went to my friends, who's I just named just before, as well as another good friend of ours, Gary Jacob, in LA.
Yes.
And I started talking to them about this, and they started saying, yeah, this is something that is identifiable and codifiable. Let's call it something. And as we were having that conversation, we ended up with clinical reasoning in spine pain, CRISP, CRISP. The short term is CRISP, clinical reasoning in spine pain. Basically, applying sound clinical reasoning, applying the biopsychosocial model in figuring out what the diagnosis is that is multifactorial in each individual patient, and then figuring out what is the best management strategy that is most likely to respond to the specific contributing factors in each individual patient. And that is what resulted in clinical reasoning in spine pain.
It's absolutely fascinating growth and evolution, and the idea of then finding a way to organize it, make it practical, make it repeatable, and be able to teach that and to grow. So then, as a result, that led you to starting to teach through the University of Pittsburgh, right? And teaching the CRISP model.
Yes.
And then also starting to get back to your writing, and led you to a couple more books. So tell us a little bit about that.
So I realized that, here we go. There's 2 more books that need to get out. So in this whole process, I identified I still got more stuff in me that I had to get out on paper and get out there in the world. And so that resulted, because the reason is because this CRISP approach that I identified and codified and recognizes the structure to, okay, now I have to get this out in the world. And so that's what led to me writing the two books. So I started on the low back book in 2013. And so I guess basically writing down, committing to paper the thought process that I was just explaining that led to clinical reasoning spine pain. Okay, now I've organized it in my mind. Now it's the next step is committing it to paper so that I can put it on a page, more than one page, whole bunch of pages. And which ended up being a book. And
Right.
so in 2013 I wrote and published the low back volume one,
Mhm.
and then in 2016 the volume two, which is cervical and thoracic. And they also included in volume two case studies in primary spine care, basically case studies, cases where, okay, this is how the CRISP approach can be applied in primary spine care. And here's the process that we go through to lead to the diagnosis, and then to stop and say, okay, how's the patient doing? Are they doing well? Are they doing not? If they're not doing well, okay, what do we do now? Or even if they are doing well, what do we do now? And going through that whole process of basically taking good care of a patient as a primary spine practitioner. And so that is how that all evolved into those two books.
Fascinating. It's interesting. In my practice, I sold my practice 2 years ago, so now I'm semi-retired. I do medical legal work, and I still work with a few patients, complex cases, and professional athlete, still. But in my last, I'd say, 15 years in practice, I got involved with an insurance company, and it was like an HMO, and they started looking for chiropractors, and it was for around the southern Los Angeles area, the South Bay area, and they had quite a few. It was a hospital-based program initially, and they ended up having only 2 chiropractors in the region. I was one of them. And so those last 15 years, a large portion of my practice was referrals from all of the primary doctors in that group. And there are a lot of them. There's well over 100. The company kept getting bought and expanding out, and it ultimately became what we know as Optum today, but which is pretty well known across the country, I think. And so I ended up, a part of my practice was exactly this, where the primary docs say, well, this guy's, they've got this chronic back pain. And I think adding on to what you talked about was the idea, when we get out into practice, instead of thinking, how can I get my practice to be busier? How can I increase my income? I think the right attitude is, how can I become more of a resource in my area? And to do that, you have to reach out, and you have to find out what the other clinicians' problems are. Those patients who, they say, oh, Mrs. X is coming back in, and I've seen her 4 times, and I've given her this types of medications, and it's not working, and I can't, and where do I go? What else can I do? And instead, what they'd prefer to say, go see Dr. Murphy, because he's an expert in these kinds of things. And I can't see anything here where it looks like you need surgery, but you've just got chronic back pain and recurrent, or neck pain. And so this guy is the guy I'm sending you to, and I've had really good results with him. And this is, for those that are younger, can't understand what a difference this is from at least when I started practice in 1982. When I started, there was only one orthopedist in the entire South Bay that would accept a referral from a chiropractor. One of the first patients I saw had neck pain and headaches, and I started seeing him, gave him several treatments. He was very happy, and he was improving dramatically. And then he came one day, and he was coughing, and congested. So I listened to his lungs and I said, I think you have pneumonia. You need to go see your primary doctor. And he called me back a few days later. He says, I went to my primary doctor and he said that I was, you are right. You had pneumonia. I have pneumonia. But so I wanted to, and he was very impressed that a chiropractor would be able to catch that. And he says, and I also need to cancel my next appointments. And I said, well, why? He says, oh, because he said that chiropractors are quacks. And I said, but I just cut your pneumonia and you're improving. He says, yeah, but he's been my primary doctor for 30 years. And I always follow exactly what he says. So I'm sorry and thank you for what you've done, but I never saw him again. So this is kind of the way that it started for me in the early days. And so for us to see now decades have passed and the integration, interprofessional integration, and I'd like to think that we've had a little tiny piece of that, right? Mm-hmm. And what you're doing now is more than I think a tiny piece, because I think there's so much discussion now on the costs of chronic pain and the costs, and both in from a financial terms and the human cost, which I discussed in my book. We've discussed in our books, and I know you have. But now we're looking at really from a practical quality of life and also an economic perspective, and the amazing, incredible cost of chronic spinal pain, and the potential impact we can have if we can grow this model, this brilliant model that you've brought forward with you and your colleagues, with our colleagues and our long-term friends who I've known also and been very fortunate to know and to learn from and to learn with. And so I'm wondering, what kind of traction is it gaining, and what kind of resistance do you find to try to grow your CRISP model?
Yeah, good question. So it's been a challenge because, number one, as you were mentioning, as everybody knows, healthcare costs are out of control in our healthcare system.
Yes.
And the messiest, most expensive, and most disorganized, and the area with the worst outcomes is spine-related disorders. Actually, the most expensive area in all of medicine is neck and back problems. The second most expensive area is all of other musculoskeletal problems. So basically, musculoskeletal problems as a group are by far the biggest driver of the incredible expenses that we're seeing in healthcare. And so we're the response to that. We're the answer. And, I talked about this, as far as general musculoskeletal, because one of the things that bits of pushback that I would get from chiropractors and physical therapists as well, when I was talking about the value of becoming a primary spine practitioner, is that they would say, well, but I don't want to limit myself to just back and neck problems. I want to see shoulders and knees and ankles and hips and all that kind of stuff. And I said, well, go ahead. Exactly. And actually, taking it a step further, I used to talk about this so much that people have actually come to call this Murphy's Law, because in my experience in private practice, I'm passionate about spine. I love seeing spine-related disorders. I would be perfectly thrilled to see nothing but lumbar, thoracic, and cervicogenic problems. But as I was going through this process of gaining referrals from primary care practitioners and from specialists, what started happening was they would say, well, oh, your shoulder hurts? Well, Murphy's really good with spine. Why don't you see him about your shoulder? And I was getting more and more referrals of extremity problems, even though I was actively trying to avoid extremity problems. So the lesson being, if you want to see back and neck problems, you want to see spine, but you want to see other musculoskeletal problems as well, so become a primary spine practitioner. The best way to generate referrals for extremity problems is to establish yourself as the expert in spine. And you can't avoid other musculoskeletal problems, because I've tried to avoid them and I couldn't. So that's the other important lesson here. And so what this evolved into was that we formed a company, myself and Brian Justice and John Ventura and a few others, that we said, well, we need to take this, all this stuff that we're talking about, we need to take this to the world, to the marketplace. And so we formed two companies. Number one was Spine Care Partners, and the other one is what we now call MSK Navigator. The MSK Navigator is for practitioners, for professionals who are interested in going in this direction to establishing themselves as the expert, the primary spine practitioner who also takes care of other musculoskeletal problems. And they want to establish that as a professional niche, as also in establishing that in their community. And so we started those companies because we have to make this more broad. We have to generalize this to, if we're really going to have the impact and make the changes that need to be made in the healthcare system. Now, the challenge is that why do we have runaway costs in our healthcare system, and why is spine and musculoskeletal the biggest drivers? Well, because there's a lot of people in the healthcare system who are highly incentivized to do as much stuff to people as possible. They're not incentivized to take care of people. They're incentivized to do stuff to people. Injections and surgery being the most highly profitable things, and so that's what we do. So
Right.
the healthcare system is trying to change that and bring value, and it's well on its way. So if we do bring value, who's going to take care of those patients? It can't be specialists because they don't know how to do high value spine care and musculoskeletal care. Who's going to do it? And we step in. We'll do it. We'll take care of those patients up front, provide high value care for patients with spine and musculoskeletal problems, coordinate referral to those specialists who do need to see those patients, coordinate referral for differential diagnosis, for imaging and blood work and other specialists and that kind of thing. We'll take care of all that. That's where we stepped in and decided to, again, make this more generalizable.
I think it's brilliant. That's interesting. I mean, we've really gone along even more of a parallel path in these last couple of decades than I've realized, because I love working with extremities also in addition to spine. And Professor Yana used to always tease me because he knew my favorite joint complex was the shoulder. I was fascinated by the shoulder, the complexity of it, the increased motion, mobility and capacity of it, and something because of it that makes us uniquely human. And but at the same time, as I was getting referrals from primary doctors through these healthcare groups and kind of through the area, then your reputation spreads and all of that, your publications and all that. It just and I would always go and I would always observe surgeries. So I made relationships with orthopedists, and then I'd say, but if this is a surgical case, I want to be in there. And I want to see what's going on and teach me, what you're doing and why you're doing, how this can help, so I can understand more about it. I can explain it to my patients better. But what happened was exactly what you said. I ended up starting getting referrals from them, especially we already had Dr. Greg Yoshida, a UCLA spine surgeon, and almost 15 years ago, I moved my practice into his building so that I could work more closely with his group. And what he just found is, he said, you're getting me better results because you're clearing out the cases that are not surgical. And so, for example, he'd start sending me all of his stenosis cases and radiculopathies, anything. He said, you see if you can get them better first, Craig. You get and the ones that, because I know I've got really, really good surgical cases. And that's what he was interested in. He was a guy who was big on saying no to spine surgeries where other spine surgeons in the area were more aggressive. And so that what happens then with time is you set your standards, your parameters, then you start working with like-minded individuals of different areas within healthcare, albeit whether it's physiotherapists or surgeons or primary care, because you're all talking the same language and thinking along the same lines. So I'm so fascinated by this. we are running out of time today, and this is I think we could just easily talk for the next 5 or 6 hours with no problem, without any breaks, because I'm so excited to be speaking with you, sharing information, finding some overlaps that I didn't even realize existed. But I think what I'd like to close with is just a final quick question, which is if you were to look back in time, if you were thinking about becoming a chiropractor, going to school, and then looking ahead and say, now what you're going to do in your life is you're going to write three books, and maybe even more, and publish 80 papers, and this is going to put years and years of your life extra in addition to your treatment. It would have looked daunting, but what right? You would say, well, forget it. Maybe I'll go back to the beach. So what I would like to know is, I always felt like I never worked a day in my life once I got into practice, because it was. I'd like to know what were your key drivers that led you to pushed you so that you weren't pushed to do it. You didn't have to do it and come in. You chose to. You wanted to, and you had this in you to get it out. What led to that?
The one word that comes out is passion. Yes. I had passion. And once you have passion, then everything evolves from that. And like you say, it can't be work, because if you're following passion, that can never be work. And so that's really, I found my passion. And then everything, I can say everything took care of itself. There was a lot of challenges and I had to do a lot, of course, but basically the whole thing flowed out of that passion that I found is inside of myself. How I found that passion, I don't know. I'm just glad I did.
100%. Well, with that, I must thank you so much for taking the time to join me out of your busy day. I'm going to ask you even now in advance, down the road, I'd definitely like to do Dr. Don Murphy to ACEs Optimist Part 2, and I'm already looking forward to that. And thank you so much for joining us today.
That's fine. Thank you for having me. It's been a lot of fun.
Great. All the best. Take care.
We'll do this again. Okay. Bye.
All right. Bye, everybody.
Thanks for tuning in to this episode of the ACEs Optimist Show. Catch you on the next one.